what we're talking about, as Pat mentioned earlier today, is hospitalizations and emergency room visits, and in particular, how to manage those. I think if you've been a dementia caregiver for any amount of time, you do realize that it's almost inevitable that you will deal with emergency room visits or hospitalizations at some point in time during the dementia journey. So the skills you need are those that help you manage those so they have the least impact on your loved one that you're caring for. Let's talk for a minute before we start about why, in more detail, are we talking about this topic as part of what we consider the basic information for all caregivers. One of the reasons that we're talking about this is because of what I just said. It's almost inevitable that at some point in time in your journey as a caregiver, you will be faced with an emergency room visit or a hospital visit. Statistically, a person living with dementia is twice as likely to seek emergency room care and to be admitted to the hospital as compared to an older adult without dementia. And about 85% of people who have dementia have one or more other coexisting medical conditions like high blood pressure, diabetes, that also can cause problems and frequently do during the dementia journey. The other reason we need to talk about this topic is related to outcomes of hospital visits. In general, about 75% of the people who are 75 or older and functionally independent at admission to a hospital are not functionally independent at discharge. Another way of saying this is that 1 person in 4 who's living with dementia, or about 25%, are discharged from the hospital at the same functional level at which they entered the hospital. About 2 in 4, or 50%, are discharged with a functional decline that is at least 1 level below where they were when they entered the hospital, and usually require additional support services. And about 1 in 4, or another 25%, have a more significant functional decline at discharge and die within 3 to 6 months. So emergency room and hospital visits can clearly cause significant problems for people living with dementia. In addition to that, it's estimated in the United States that somewhere between 20 and 40% of hospitalizations are preventable. And these same statistics apply to people with dementia. In stressful situations, it's typically the caregiver who decides when a person needs to go to the emergency room and who pushes for hospitalization, perhaps, as opposed to deciding that that person needs to be managed at home or can be managed at home. So why do we make hospital visits? There are a number of reasons, and many of these are related to the pre-existing conditions that frequently co-occur with dementia, but may be exacerbated by the dementia. The first is falls and fainting. Falls seem inevitable as dementia progresses, and falls may be even more prevalent in individuals who have Lewy body dementia than with other kinds of dementia because of their Parkinson-like symptoms and because of the autonomic dysfunction or the fluctuations in blood pressure specifically that occur as part of LBD. Remember, when we think about that many dementias are mixed. So these symptoms can occur in any dementia, even if Lewy body is not part of the formal diagnosis. Another reason for hospital visits is heart disease. This includes heart failure, heart attacks, coronary artery disease, and heart arrhythmias. These may result in decreased blood flow to the brain, which is already compromised. And heart disease is still a leading cause of death for all individuals over the age of 65. And dementia does not make one immune to that statistic. GI disease, there's structural changes in the large intestine as we age, plus the lack of exercise that occurs frequently with people with dementia, not drinking enough fluids, can all result in constipation, as can medications that are being taken for other medical conditions. Constipation is uncomfortable. It reduces the appetite. It can lead to urinary retention or retaining urine in the bladder, can cause confusion, and in extreme cases can cause something called a fecal impaction, where it's impossible without that impaction being removed for the person to begin to have appropriate bowel movements again. COVID and pneumonia are both considered respiratory illnesses. COVID is now the third leading cause of death in older adults. Research shows that the person living with dementia is twice as likely to get COVID when compared to a person without dementia, even after adjusting for age, sex, living in a nursing home, and having similar pre-existing conditions. So COVID is a real big issue still in terms of problems for people who have dementia. Pneumonia is one of the most common causes of death in older adults with dementia. In general, people with chronic diseases like diabetes, heart disease, and lung problems, all of which are prevalent in the older population, also have an increased risk of pneumonia. So you almost have a double whammy there. Inactivity, pooling of secretions, and aspiration are common as dementia progresses. Several studies have reported that people with dementia tend to die more often from pneumonia. And that is actually they tend to die at a rate that is 2 times greater if you have dementia than for those without dementia. Urinary tract infections, the bladder weakens as we age and the pelvic floor muscles weaken, and in men, they frequently have enlarged prostates, all of which make it difficult to empty the bladder completely, or conversely cause some kind of incontinence. Incontinence itself, especially in females, is a risk factor for urinary tract infections, as is being overweight, nerve damage from diabetes, and certain medications also have an impact. A urinary tract infection causes pain for the person living with dementia, and they may not have the typical symptoms that we expect in other adults. It also may cause incontinence that's new and changes in their behavior. There's at least one study that I came across that lists caregiver depression and exhaustion as a reason for hospital visits. And I think those of you who've been a caregiver for any amount of time can understand that. There are times when you just reach the end of your rope and think, I can't do this anymore. And if the least little thing goes wrong physically with the person you're caring for, it's that little nudge that kind of pushes you over the hill and down the other side in terms of seeking help for dealing with whatever is happening. And the last reason that's common for hospital visits is delirium. And delirium is so important that I want to spend a minute talking about just about delirium itself. Delirium is an acute confusion, so it happens over a short period of time, sometimes within hours or days at the most. It may cause hallucinations or for a person to become paranoid. It may cause increased activity, decreased activity, or the person with delirium may alternate between the two. It's critical to identify and treat any underlying conditions that may cause delirium quickly. Delirium is frequently mistaken for a sudden worsening of dementia. And it may be caused by a combination of stress, infection, and/or pain. But it may be reversible if it's identified earlier. Delirium is associated with very poor outcomes, including death. Roughly about half of all patients who have delirium will die within 6 months. Even if the delirium is treated and addressed in a timely manner and resolved, it may hasten cognitive decline. At least one study showed that there was a cognitive deterioration that was roughly twice that of a person living with dementia who didn't have delirium, that occurred for up to 5 years after a hospitalization. So a cumulative effect, not just the effects or changes that you see right at the moment of hospitalization. The longer delirium lasts, the poorer the outcome. And for some reason, delirium, it occurs more frequently in individuals with Lewy body dementia. So it's something you need to put on your radar to pay attention to and to think about if things change very suddenly with the person for whom you're caring. So what causes problems during hospital visits? Imagine for a minute being on a stretcher, perhaps strapped down because someone did that to get you to the emergency room if you went via ambulance in order to keep you safe. There's strange people coming at you and talking to you, but you don't understand what they're trying to say. You have someone wrap a blood pressure cuff around your arm and it squeezes your arm and it hurts. And you're being stuck for an IV, all while you're in a strange place. Add to that lots of light and loud noises, and it's very easy to understand why a hospital setting can be very disorienting for the person with dementia. The other thing that happens with hospital visits with people with dementia is that there are frequently new medications that are added. More than 50% of the people living with dementia who visit the hospital have at least one medication added to those they were already taking. And one of the things that seems to be a truism about medication is that once medications are added, they're rarely taken away. So if a new medication's added, it is on top of whatever else that individual was taking. In many instances, there may be multiple medications added at one time. For example, antibiotics to treat an infection and a medication for agitation because the person's in those unfamiliar settings and has all those things going on that they don't understand. And unfortunately, still way too many staff who work in hospitals are unfamiliar with dementia. Hospitals are built on routine and adherence to procedures, neither of which works very well for a person with dementia. The focus most frequently in the emergency room is on the presenting problem, or what's the main reason you came here, and other factors are ignored. And unfortunately, also, especially in this post-COVID age, hospitals are frequently understaffed for the number of people that they serve. So what kind of problems that are new can we expect after a hospital visit of any kind? Again, delirium can occur because of the visit. Remember that stress can be one of the precipitating factors for delirium. Falls and fall-related injuries are common. The person who has dementia is frequently weak already to some degree when they enter the hospital. They're, again, as I said, often confused. They're unfamiliar if they're admitted or even in the emergency room with the bed they're in and the room they're in. They likely don't understand how to use a call bell if they need assistance. They're more likely to use a walker or some other aid for ambulation. And in general, the fall risk in elderly people with dementia who have an abnormal gait and balance is 3 times greater than for an elderly person with dementia who has a normal gait. These individuals are also more likely to have urinary incontinence and vision problems, so they may be in a hurry to get to the bathroom and yet can't see well enough to know where they're going or to navigate their surroundings. Another new problem that commonly occurs is skin tears and skin breakdown. These increase the risk for infection, immobility as they heal, and for pain. There was a 2000 study reported in the Journal of the American Medical Association that compared the number of procedures that patients had and the pain relief that they received if they were admitted for hip fractures. Those with dementia had the same number of procedures, but received 1/4 of the amount of pain medication and 3 times the number of antipsychotics. The most frequently given antipsychotic was Haldol, which if you've listened to any of the previous information on medications to avoid, and particularly if you have someone with Lewy body dementia, that's very, very high on the list of medications to avoid at all costs. The next most common antipsychotics were Seroquel and risperidone, both of which are not as bad in terms of side effects as Haldol, but they can still cause sedation that makes the person more confused, a decrease in blood pressure, cardiac arrhythmias, difficulty walking, and those anticholinergic effects that Pat talked about in another session, things like constipation, dry mouth, blurred vision, and urinary retention. The functional decline and the increased risk of death that are new problems during hospital visits we've already talked about. But as you can see from this list, the outcomes of hospital visits and trips to the, whether it's a trip to the emergency room or admission, can be really significant for a person who has dementia. So given all of that information, what's a caregiver to do? The number one recommendation is that you take care of yourself. Now, that seems counterintuitive when what we're talking about is whether someone needs to be in the hospital or go to the emergency room. But the reality is that if you have not put some effort in taking care of yourself, your capacity to think through situations and to problem solve and make decisions is significantly diminished. And that capacity needs to be functioning at the highest level possible if you're faced with decisions about hospital visits. Secondly, remember what we've said in previous lessons, that dementia caregiving is a team sport. Have at least one member of your team that you can depend on, who understands your priorities and who can help you think through decisions when you have to make decisions either prior to a hospital visit or during that visit. I can give you a personal example of this. When my husband Roy had Alzheimer's and probably some vascular dementia, and one of the commitments I had made in thinking through what was best for him, and in my promise to him early in the process that I would never do anything to prolong his life, was that he would not be admitted to the hospital. That whatever happened, we would handle it in the family care home in which he resided at that point in time. What happened with Roy was unexpected from my perspective, although if I think about the leading causes of death in individuals, it's not unexpected from that general perspective, and that's that he had a massive heart attack. I happened to be there when he started having symptoms, and all I could think was, we got to figure out how to handle this without going to the hospital. This was also during COVID, by the way, which added another layer of, can we avoid the hospital to it? One of the symptoms that he was having was, in fact, a major symptom was significant chest pain, and he was clearly hurting. We weren't prepared to deal with that kind of pain in an assisted living facility. And I was basically, because I was surprised at what was going on, and because I was wrestling with my previous decision not to take him to the hospital under any circumstances, really going around in circles. Fortunately, I was able to call my younger daughter, who was the closest one to me and was there in about 10 minutes. And she also happens to be a nurse, which is helpful. She quickly assessed the situation, and what she said to me is, "Mom, we have to go to the emergency room. There is nothing else we can do here to make Dad comfortable," which was true. But I was spinning, and her having the information about what my commitment had been and what her father wanted, and putting that into the current circumstances, made the decision to take him to the emergency room really the only logical one we could make at that point in time. Decide what's important in terms of quality of life and length of life at this point in the dementia process. What's important to us changes as we get further into the dementia journey. So we're having to constantly reevaluate what quality of life means at this point and how that interplays with length of life. Ask yourself, what is it that I want for this person? Or perhaps if it works better for you, that I think this person would want for himself at this point in time, given where we are cognitively and physically. Think about what makes sense for the person, not just about what's possible to do. For example, with Roy's heart attack, it was possible to do a cardiac cath, to put in stents, and perhaps to halt the process. But that didn't make sense for him, given where he was with his dementia and given the most sacred promise I had made to him of doing nothing to prolong his life. Know what's important and convey it to family members, to other caregivers, if the person's in the facility, to the facility staff. The best way to convey information on what's important and what actions you want taken if a person is in the facility is through making sure that what's called a MOST form, and that's an acronym, MOST, which stands for Medical Orders for Scope of Treatment. That's the form in North Carolina. It may be different in other states. It may be called in many of those states POLST, POLST, or Portable Medical Orders, which again tell the facility, if you're not there, what the priorities are and what kinds of interventions are acceptable. There is a video on the MOST form that's on Pat's YouTube channel. And if you aren't familiar with those forms, I would encourage you to look at that video. Again, make sure that your support person or persons stay aware of what your current thinking is. Discuss what to expect with this kind of dementia, again, at each point in time, with the primary care provider or with the specialist who may be a neurologist or gerontologist who's seeing your loved one. Ask them about the changes that you might expect, the progression of the dementia, again, based on where the person is at that point. Talk with other medical care providers about how one of those comorbid diagnoses or coexisting conditions impacts dementia and how dementia impacts that condition. Make sure that all of the medical providers who are involved in your loved one's care are aware of your goals for care. Ask questions like, what should I do if he falls? When do I worry about falls? When is it okay to watch things at home? What can I do if I think she has a urinary tract infection? What can I do if I think she has pneumonia? Think about services from palliative care or hospice program if those are appropriate at that point in time, because that also adds a medically knowledgeable person to your team who knows you, who knows your loved one, and who's on your side when it comes to interventions and decision making. Understand the pros and cons and the alternatives for any treatment that's recommended for your loved one. Ask the question, what do we hope to accomplish with this? Don't be afraid to ask for clarification. And always ask, again, what difference is this going to make for my loved one? Don't be afraid at any point in time to opt for comfort care only. About 2 years before Roy died, he had a stroke. And I had a MOST form. And I won't go into any detail, but I was about 2 hours and 20 minutes away when this happened at my parents' house. And the facility, the nurse in the facility was determined he was going to the emergency room. Fortunately, both of our daughters were close by and could intervene. What I knew, that I knew from my medical background, but that you can get information from asking these questions, is that when someone has a stroke, it's caused by one or two reasons. One, they have a bleed into the brain that's spontaneous. And there's nothing you can do about that except watch it and see what happens. Or secondly, they have a blood clot. If you have a blood clot, the typical treatment if you go to a hospital early is a clot buster. Well, early in his dementia, Roy had been on blood thinners for atrial fibrillation and had had a significant fall where he fractured his skull in 3 places and bled into his brain. As a consequence of that, he was never going to be appropriate to have a clot buster or any other blood thinner. So what's the point in going to the emergency room? If it's a bleed, we're just going to watch it. If it's a clot, we can't do anything about it. So that to me was the perfect example of when comfort care, keep him where he is, where I can have more control over things, and make sure he's comfortable. Be able to describe if something goes wrong or is happening with your person living with dementia, what that person's typically like, and what differences you're seeing. It's important to be as specific as possible when you're describing these differences to someone else. You know this person better than anyone else, so you see changes that other people may not pick up on. For example, is he sleeping 20 hours a day now when he used to just sleep 9 hours a day a week or so ago? Has he stopped eating anything and he's only drinking 8 ounces of fluid in a day? Does he moan and grimace all the time, even when he's just lying in bed? Is she pacing the floor for an hour or more at a time and trying to hit out at anyone who tries to calm her down or even speak to her? If you think pain is an issue, and it frequently is an underlying issue for changes in behavior, I would suggest that you try Tylenol. We underestimate the benefits of Tylenol for pain control, but it's a very appropriate first-line approach for most people with mild and persistent pain. Again, going back to medical studies, there are studies that show that 60 to 80% of nursing home patients with dementia regularly experience pain. And 1 in 3 of those residents have moderate to severe pain. Patients with severe dementia experience more pain than those with less severe dementia. So pain may be an underlying reason for many of the changes that you're seeing in your loved one. And unless there's some contraindication to trying Tylenol, I would talk with your doctor and make sure that that's something that's appropriate and what's the maximum dose you can give to see if intervention for pain control might solve the problem rather than going to the hospital or the emergency room. Other things that help with pain are physical movement, music, massage, heat, sometimes lidocaine patches. Human interaction helps a lot also. So keep all of those things in your bag of things to try if you think pain may be underlying some of the things you're seeing with your loved one. Be proactive if you think that problems are developing. Think like you did if you have children, when you had young children and you were approaching 3 o'clock on Friday afternoon and they were kind of sick and you didn't want to go into the weekend without knowing what was going on, knowing that if you took them to the doctor, they would be all right. And if you didn't, you'd have all kinds of trouble within the next hours, starting after about 5 o'clock or when the office closed. Know how to best contact the regular medical care providers for your loved one, especially if you need guidance urgently? Is it always better to use the patient portal? Or is a phone call better? Is there a difference in which you use if it's an urgent problem plus just a problem that's in the early stages of developing? What are you supposed to do after hours? Are there extended office hours for your providers on any days? Is telemedicine an option? Can I bring a urine sample by the office if I think it may be a urinary tract infection? What if I've done a home COVID test and it's positive? So try to think through all of those and get ahead of them in terms of knowing how you might best respond to all of those situations. And always have medical information ready in case of an emergency. That information needs to be current and should include current medications. And I kept Roy's medications updated on the computer, and ultimately, multiple years into this process, developed a table where I listed a medication, what dosage it was, when it was started, a date if it was discontinued, any problems that we encountered with medication, particularly why it was discontinued. Because in a situation where there's so much going on, it's very difficult to recall that information. And sometimes having had a side effect from a medication is a good reason to question whether that medication should be used again in the future. Make sure you include allergies and all current diagnoses, not just the dementia, but all those other coexisting conditions. And that you have some listing of who, if there are multiple providers involved with your loved one, who those providers are and how to get in touch with them. Make sure that you have a listing in very large and bold letters that says, do not give these medications under any circumstances, especially if your loved one has Lewy body dementia. And then the typical things that you need to have in that emergency information, insurance information, any advance directives and healthcare power of attorney, and anything else that might be helpful to the staff to better understand your person living with dementia. So you've done all of this, you've got all of this together and you followed it carefully, but you still end up at the emergency room or in the hospital. Then what do you do? First of all, remember what I said earlier. Don't expect staff to have the expertise that they always need in caring for persons with dementia. Try to make sure that either you or another member of that care team you've got stays with the person living with dementia at all times. That will help keep them calm and allow you to know what's going on and advocate immediately for them if something's happening that's not the appropriate thing for your person. Be prepared to help any staff in the hospital, whether it's the emergency room or after a hospitalization, to understand dementia in general and the specific needs of your loved one. Make sure they know things like what name he prefers to be called or what things agitate her. Control the environment as much as possible. Don't hesitate to ask to turn down lights, to try to turn down any noise that it's possible to have an impact on, if nothing else, to keep the door to the room closed, to shut out some noise, to ask if you can use music or white noise. make sure that you're the one that gets to explain what's going to happen if somebody comes in to do something. And if it's possible, sometimes there are objects in the home that are particularly comforting to an individual that you may want to consider if he or she's admitted to the hospital to have in the room. Know your rights and your hospital resources. If you're like me, you've seen a patient bill of rights because you go have an outpatient procedure, or you go for a routine mammogram, or whatever else. You've seen it so many times that, number one, you probably don't pick up a copy of it anymore. And number two, even if somebody hands it to you, you don't really read it. But those rights can be really important as you advocate for your loved one with dementia. Here are some things that it says in the UNC Hospital's Patient Bill of Rights that are particularly pertinent to individuals with dementia. A patient has the right to be treated in a dignified and respectful manner. That probably looks different with your person with dementia, but they do have the right to have that. To have good quality care using high professional standards. Except as medically necessary, a patient has the right not to be awakened, to be free from duplicative procedures or repetitive procedures, and to avoid treatments that cause discomfort. A patient has the right to effective communication in understandable terms. And if you are the power of attorney, you are, in fact, that patient at the time, which means that you have a right to effective communication in terms that you can understand about what's going on. All hospitals now have a department that's called patient advocacy, or a person who's called a patient representative. These people work with families to help understand their concerns and resolve issues when there are problems in the hospital. And they also work in emergency rooms. They usually work directly with the patient and family to do that, and can perhaps be a good advocate if you are encountering difficulties in the care for your person with dementia. Hospitals are also required now to have ethics committees. These committees don't usually make decisions about an individual, but they can facilitate discussion between parties and advising on known statutes and regulations, but more than anything else, making sure each party understands and really hears what the other party is saying. I talked with a high school classmate whose wife, who was also a high school classmate, died a couple of weeks ago. And he said that when she was in intensive care, and she did not have dementia, this was a sudden hospitalization, but she went into renal failure and liver failure both. The person who talked with him about what her status was, and basically that they had run out of options while she was in the hospital, was a representative of the ethics committee in that hospital. So those committees, depending on the hospital, can have a pretty big role in advocating, in helping you understand and make sure that you're supported in the decisions you make for your loved one. So a trip to the hospital may be unavoidable, but our role as caregivers in those situations is to minimize the negative impacts of the trip while advocating strongly for what is best for our loved one living with dementia. Doing this takes thought, conversation with multiple people, and support for you in the process. Thank you. There is one more slide that since you are online, you can take a picture of. These are 4 sites that I found that I thought were particularly helpful and will provide some additional information to you to help you better manage any hospital visit, whether it results in an admission or not.